did the gene site get uploaded with that case information?
No, I didn't see it.
Shoot. Okay.
Do
Well,
you
that
have
was
it? Do you have it that you could show it on the screen real quick, or do you have a summary of it?
probably. Just realized that it didn't get attached. I thought we sent it in. I can print it and run and get it real quick.
That's
The
okay.
most
Do you remember what? So it's a report of sort of enzymatic deficits in how people process certain drugs. Was there a specific enzyme that was a slow or a fast metabolizer? Do you remember that?
Yes. Well, the interesting part of this case, I just recalled that we had talked about GeneSight a couple of sessions ago. And so I had a GeneSight on a young lady that came back, nothing in the green, and 3 that were in the moderate, and then everything else was in red. And the interactions were anything from the serum level may be too high, lower doses may be required. The use of this drug may increase the risk of side effects. FDA label identifies a potential gene drug interaction for this medication. So I just thought it was an interesting case. I've not gotten a GeneSight back that had that many drug interactions. And so kind of the GeneSight was kind of the interesting part of this case.
Well, so that, it's rare that you see that many. So usually what that means, and the color that it shows up, the red, yellow, green, the moderate, doesn't always tell you if they're an ultra rapid or a slow metabolizer. But if they're telling you in that red column or in the moderate yellow column that there's a higher chance of side effects, that still means you need to be very cautious and start out very low with the doses. This was a case, I don't know if everybody had access to the case, but this was a case with severe obsessional anxiety, social anxiety, panic attacks, just anxiety coming off the page. I think it fits nicely probably with our lecture today. From a medication standpoint, the most evidence base would be to try to optimize an SSRI, perhaps an SNRI. And often it's the higher, like regular dosing, it's the higher dosing of that medicine that targets some more severe anxiety symptoms. So what I would do, and maybe we could just briefly show it next week and pick, but you'd try to find an SSRI that was in that moderate category, or even, and you can even pick one in the red category, but you really have to go extremely slow. So I know she took Lexapro, was it Lexapro, I think, and at 10 and couldn't tolerate the 10 milligrams. Sometimes you have to almost micro back dose some of those medicines. And so in someone that has that severe of a profile, I usually would pick an SSRI that has a liquid formulation. So that's Zoloft, Lexapro, or Prozac. And I would start at 0.5 milligram, 1 milligram kind of dosing and go up very, very slowly. It doesn't mean they can't tolerate it. It just means that the dosing is so slowly metabolized that 5 milligrams might act more like 60. I'm being dramatic, but and they're just going to really get those side effects. So in most of the cases, you're doing substantial dose reduction, starting very, very low, going very, very slow, and monitoring for the side effects and risk benefit response. But it also may suggest, I mean, depending on what's on the list, there may be other non-SSRI options that could be explored for anxiety. Sometimes looking out at GABAergic medications has some evidence for some people for anxiety, not specifically OCD necessarily, or beta blockers that act in a different system. And those are not always on those reports. So sometimes GeneSight leaves off the beta blockers and some of the GABAergic medicines because they're not as commonly used psychiatrically that could be explored. But I would love to actually see the report and see if a low dose path could be helpful, because it doesn't sound like she's ever actually had a decent medication trial. The other issue is maybe she can't tolerate the medicines, or maybe the fear, the side effects is so high, and you really rely on the importance of psychotherapy for anxiety. And I think I'm going to lead like right into the talk today, because for people that have that level of symptomatology and lots of med side effects, psychotherapy can actually be incredibly helpful as well, and might sometimes be more relied upon the medications if people have failed medicines or can't tolerate medicine. So I'm curious, do you remember any of the medicine names that were in the yellow column? Or
Christique was one, and then I think the other two were older, obsolete meds that we don't use anymore. I'm trying to pull it up.
So Pristique has very limited. Pristique's usually the one that sort of doesn't have much of the drug interactions through the liver metabolism pathways. It's an SNRI, kind of is a variant of Cymbalta in sort of a way, but it has a better tolerability profile. I mean, it could certainly be a consideration, especially for some of the generalized sort of anxiety there. But again, it sounds like it still is going to have to be dosed on the lower end, and that certainly wouldn't be unreasonable to try. Less evidence for it for the OCD. Although I'm curious, and since we're talking about OCD today, I saw so much social anxiety, more racing, daily worry. I didn't hear as much of the true intrusive OCD type thoughts. So that might be kind of an interesting thing as we transition into the OCD talk today. Was it just kind of anxiety everywhere, or were there actually some true like intrusive thoughts and repetitive behaviors too?
No, she did. She considered herself having OCD, but I really got more anxiety, generalized anxiety from her from the interview, but she felt that it was more obsessive compulsive. But I
Well,
didn't.
maybe this today will help everyone else tease that out, but I agreed. It sounded like a lot of generalized sort of and social worry from the case. But I'd love to see the gene site if we could show that next time, or if you want to send it out, they can send it out to us. I like looking at those. I'm sorry we didn't have that today. But I think doing that was a good example of how to use the test well when you've had someone that's attempted a medicine at a reasonable dose and had side effects. That's what I think GeneSight could be really helpful. And you got a report back that did show there was a significant metabolic issue with how that it was a side effect issue because of the way the medicine was dosed. And that's also a good use of the test when you've had people try things and had strange side effects at reasonable doses. So good choice in picking the test for the case too.
Yeah, it was.
I don't know if anyone had any thoughts.
It was good because she had some, some that indicated she was an ultra metabolizer, poor metabolizer, intermediate. And I just thought it was interesting that we mentioned this a couple of weeks ago, and I thought this would be a good one to present. So I'm sorry that didn't get attached, but how about let's push this off till the next visit, and I'll make sure that it gets in this time.
Sounds great.
Okay, thank you.
Thank you. So are we doing this case now, Tracy, or do you want to wait?
We'll wait on it.
Okay, no worries at all. Then we can go ahead and move forward with the didactic. And you should be able to share your screen, Dr. Khan.
Okay, perfect. So I'm just going to try to make sure that you can see it not on presenter view. Okay, which view do you see? You probably don't see what I want you to see at this point.
No, I just saw, I think it was your email or calendar, but if you just go to the share screen on the bottom and you can select not to share your complete screen, you can select share specifically your PowerPoint presentation. And I do have it as backup if you have any issue.
How about now?
Perfect. There you go.
Okay, perfect. Thanks for being patient with me. I have
Oh,
two
you're fine.
screens, so it's like I'm always trying to figure out how to move things correctly.
Totally understand.
Okay, so this is going to be kind of basic at the beginning, but I find it really important to go over what OCD is not first. And so I think it's kind of interesting that we were talking about you know, the kind of difference between OCD and GAD and social anxiety. It can be really hard actually to parse apart, especially as we'll talk about later, a lot of these things actually do tend to coexist as well. And it looked like this was kind of one of the quotes that the patient had said, something about like, my OCD drives me crazy, or, oh my gosh, I'm so OCD. And I think that a lot of us can sometimes kind of relate that we've been guilty of this, especially some of us who are really meticulous and have a lot of anxiety and are careful and neat and organized, that sometimes we say like, oh, I'm so OCD, or something is so OCD. And I always just want to kind of put this out there that OCD is not an adjective. And actually, whenever we kind of talk about it in such a way, it can trivialize how serious and debilitating this actual disorder is. You cannot be obsessive compulsive disorder. So just because something bothers you, or you like it clean, or you're really organized, or are perfectionistic, doesn't mean you have OCD. And actually, when you talk to people who have OCD, these are the words that they use to describe what OCD is. It's really isolating and overwhelming and makes them feel all these feelings. And it's really intrusive and debilitating for many folks. So as much as we can kind of stay away from trivializing it, I think that sets a really good example. I'm also going to use a lot of, you'll see like pictures and images that kind of look like this. And it's from a website called OCD Doodles, which is someone who actually has OCD who like creates all these really nice doodles to kind of get some really good information and psychoeducation about OCD out to kind of break some of that stigma. So I just really like some of those visuals. Okay, so the DSM-5 TR, that's the 2022 most updated version of the DSM, defines OCD as having either or both obsessions and compulsions. So obsessions are recurrent and persistent thoughts, urges, images, impulses that are experienced, and they are ego-dystonic. And ego-dystonic means that they are opposite of what that person actually desires or values. These are not things they want to be obsessed with. So for example, if you were someone who came into my office for the first time, you might think that I'm obsessed with Harry Potter because I have a lot of Harry Potter stuff in my office. That is not the same kind of obsession that we're talking about. These are obsessions that are intrusive. They are not wanted. They cause a lot of anxiety and distress. And because of those obsessions, the individual actually makes attempts to suppress or ignore or neutralize those obsessions. And usually that results in behaviors that we call compulsions. Compulsions are acts or rituals that help to decrease the anxiety that is associated most of the time with obsessions. So those are the behaviors like hand washing, checking, etc., that you see in many times in folks with OCD, that those individuals feel driven to perform to reduce or prevent their anxiety. In order to meet criteria for this disorder, the obsessions and or compulsions need to take at least an hour of time in your day, and they can't be attributable to any other medical condition. So for example, there are certain disorders where there are some kind of repetitive things going on, maybe like in autism spectrum disorders. It will not be the same kinds of restricted interests that you see in autism spectrum disorders, or compulsions like needing to flap your hands or other sensory things. So those are not the same. So if it's better explained by autism or another disorder or because of substance use, we would not give OCD as a diagnosis. There are also specifiers in the DSM. So most of the time, individuals with OCD have good or fair insight about their obsessions and compulsions. And you can specify that. And it's called with good or fair insight. And those are individuals that recognize that those beliefs that they're having are probably not true. But you can also specify if an individual has poor insight, where they believe actually that these beliefs that they're having are true or probably true. And then some individuals, this is more rare, but it can happen where they are delusional or have an absent insight into these beliefs, and they're just convinced that these beliefs are true, and convinced that if they don't perform the compulsion, that the obsession or the unwanted thought will happen. Also to be noted, about 30% of the time, there are some there's a relation with tics as well. So you always want to kind of parse that out to see if there's a tic-related disorder. So I really want the takeaway to be that if the before slide was what OCD is not, OCD is excessive, repetitive, distressing, impairing, and time-consuming. It gets in the way of being able to have normal or typical functioning in many life domains. Okay, so obsessions feel for the individual with OCD like you are stuck, you are on a loop. These are not things that are on purpose or chosen to be had. They are really distressing thoughts like, what if I hurt someone or myself? What if I'm contaminated? What if I don't really love someone? What if I lose my mind? What if I'm bad? Am I real? Is this a simulation? And these thoughts get stuck and occur and occur and occur, especially more as efforts are made to reduce or prevent them. They trigger anxiety. They can be very fear-provoking. And some common thoughts or themes that we see are related to safety or contamination, health stuff, death, rule violations, and morality or being a good person. So that obsession or upsetting thought leads to anxiety. So, that fight, flight, freeze response is immediately triggered. Obviously, most of the time, these are not real, legit, rational dangers, but it feels and is exhibited physiologically as if it is the same. And there is a lot of tunnel vision that folks are experiencing here because you are having all the same physiological reactions that you would have in a truly threatening or dangerous situation. So it feels very real in terms of the fear and anxiety. In yellow here, you'll see that there's another F, because there's the fight, flight, freeze, and then immediate this drive to need to fix it or get rid of that obsession. And that's when usually the compulsions come in. And so these are behaviors that are linked to kind of resolve or fix the obsession, make it go away. So these can be visible behaviors that are observable, or they can also be internal, something that's more hidden. They can be directly related to the obsession, or they can be totally nonsensical. So the kind of obvious or most common ones that we see are The obsession of contamination is likely linked to washing or cleaning. And those kinds of rituals can be really exhausting, debilitating, but are also visible. There's a lot of checking behaviors as well. So a need to keep safe or a fear of harming yourself or someone else can lead to obsessively checking locks or the stove, making sure you turned them off or locked them. Need for symmetry or perfection can lead to arranging. There's more touching, counting, repeating mantras, asking questions, asking others for reassurance, etc. And some of the nonsensical ones that are alluded to here kind of have to do with needing to count or needing to repeat or do things in a certain pattern or a certain order or a certain number of times in order for that anxiety to go away. There can also be some kind of quote unquote magical thinking. So believing that I have to say a word, or I cannot say a number, or I cannot have something be a certain color because of luck or because of superstitions. So there's a lot of variety of what it can look like, and truly no person with OCD at all looks or presents the same way. So some examples from those doodles that you can kind of see with the compulsions. Compulsions can also involve others. So repeatedly asking for reassurance, and we see this a lot with children, asking their loved ones or their attachment figures to kind of help them feel better, and engage them in that compulsion to make sure that they did nothing wrong, to make sure that they're good, that they're loved. It can also be just this idea of needing to do something alone or with someone else until it just feels right, asking someone else to perform a specific behavior so that they feel safe and okay. And especially if you see it early on in terms of the onset, OCD can often change, expand, and get more and more complex, where there's more obsessions and more compulsions over time, especially if it goes untreated. So I'm just going to pause there, if it's okay, to see if there are any questions about like obsessions and compulsions.
Thank you. Anybody have any questions? You can put in the chat as well. And we can always go to the end too. I have a question. Does this typically begin at a younger age and, as you said, evolve? Or do people develop it later on in life, or is it typically developed a little bit earlier and then, just continues?
It's a great question. I have a whole slide on it in a little bit. The average age of onset is 19, but certainly it does show up in childhood, and that is the population that I will see more often. And if you see early onset, you want to, identify and treat it as early as you can. Okay, so a lot of the OCD cycle, the cycle that kind of keeps obsessions and compulsions going, has to do with kind of classical learning, where we kind of talk about your feelings and your fear kind of being the motivating property that reinforces this cycle. So you have an obsession. An example is constant thoughts about like whether or not the oven was turned off. And that leads immediately to anxiety, right? Fight or flight. And that fear, that anxiety, it makes you real uncomfortable and you're compelled to do something. And for many people, fear is associated with a need to escape or avoid. And you see that across the board with anxiety disorders, but here the escape, which is a natural response for anxiety, leads to a ritual that develops, and that's the compulsion. So to kind of counteract that obsession of, is the oven turned off? Is it? I think I did. Did I do it? You would then engage in a compulsion that is going to the stove, checking to make sure it's off, and maybe even having a ritual that becomes complex related to that act, and immediately feeling relief that, oh, okay, it's off. I've checked. It's not on. And that makes you feel better, thereby reinforcing this entire cycle of I had an obsession that led to anxiety, I did the ritual, and now I feel better. And now I'm much more likely to continue engaging in that compulsion, continue engaging in that ritual. So in a person with OCD's everyday life, this can kind of look like being frustrated or having distress at being interrupted from a routine, which may or may not be obvious. It might take them really a long time to get to work or get to a task because of whatever obsessions and compulsions they had along the way. So not being able to step on sidewalks, cracks, having to go back and check their locks or the stove, having to wash and rewash their hands, whatever it is, it's very time consuming, especially if you have this added need for things to be just right or some perfectionism, where completing an assignment, regardless of your knowledge or ability to be able to do so, just takes longer or can actually not even be completed because you may erase to the point of destroying a paper. You might hold yourself to this completely unrealistic perfect standard that if it's not perfect, I can't turn it in. It's not complete. I failed. I can't do it. You can also see emotional meltdowns because of a trigger, like someone accidentally touching you or a routine getting interrupted or suddenly feeling like you're contaminated. You can also see some hoarding or inability to throw things away, even if they're completely unneeded or unimportant items, just to offset kind of that obsessive thought of what if I need it in the future? What if I'm getting rid of something that is actually important? I have included here an example on YouTube of a morning ritual. Just want to kind of ask for time if it makes sense to save this until the end, just to make sure we get through everything.
How long is the video? It's okay. We could probably do it now if you want to.
Okay, awesome. We'll try. I think I have to click share sound, right?
Yeah, I think so. Yeah, I think so.
Okay.
No worries.
Perfect. 6:20. Oh man, it's not enough sleep, but at least I have an hour to get ready for school. 5.5 hours of sleep? Is my brain gonna be okay? Who touched my stuff? Why is it not in high order? Fine. No, it'll just take a second. Just leave it. Come on, I can't just take a sec. Like that. Good enough. Almost there. It'll be really quick. Come on, school starts at 7:30. Everything's fine, just wash your hands already. Feels oily, something's not right. Doesn't take this long to wash your hands. Grimy bacteria, I gotta get it off. I'll never get it off. It's never gonna be good. I can still feel it. Get off of my hands. It's good enough. Fix the towels. Why can the towels never just be straight? Doesn't matter. The water's not evenly distributed. Who cares? You're gonna be late. Leave it. What's another second? You're joking. It's
Toothpaste
awful.
not evenly
Won't
distributed.
make a difference. It's fine.
Not even
I'll take
close.
it. There's way too much
This is
grime
not
and bacteria.
normal.
Do I have gum cancer? Alright, dude, your gums are bleeding. 5 minutes is enough. It's good. Nope, it's in there. I feel you. You're in my
There's
gums.
so much bacteria.
Are my hands too oily? There's something on my skin. Keep going and your hands are gonna bleed.
Whatever it takes.
Can't get it off my
It's
skin.
probably better
What's
than
on my
most
skin?
people.
Towel straight enough. Late again. Yeah, it'll just take a second. It's almost
That is
straight.
not straight.
Alright, school starts in like 10 minutes. Let's go. I still feel it on my
Towel is
hands.
not
straight. I don't like it. The lights.
Environment.
Got the lights. Now the lights are on in my room still. Just fix it and shut up. Oh, I knew my hands were so many fingerprints. It's actually really dangerous. It's not equal on both sides. It's gonna totally screw up my brain. It's irrational. No time. No, it's not folded straight. I come chronically crooked the lenses evenly. Shut
That'd be
up,
ridiculous.
it's not even possible. Worth being late again? It's not really a choice. You know that. No, just be in control. Yeah, but no, just stop. You needed to leave 5 minutes
Can't
ago.
leave the bed like
It's
that.
not gonna kill anyone. The dust. There's no dust, you're late. Stop. On the steps. Can't leave the bed like that. It's not healthy. Dust can get in my lungs. You're joking. Someone messing with me? No, the pressure's not even. Screw up my posture. Blood won't flow to my brain. Just the shoe. Pressure's not even. Gotta start over. Can't have brain damage. That won't happen. Stop being so annoying. No, there's wrinkles. Skin cells won't grow. Pressure's not even. You can totally feel it. It's asinine. Put the backpack on. Skin cells won't grow evenly. You feel the wrinkles. Are you stupid? It's fine. Let's go. You're late. Nope. 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 Fine. Hey, 22 minutes. Better than yesterday. Shouldn't have made the bed. It's not my fault. I had too young for lung cancer.
You pass? You're late every day.
Yeah,
So we're responsible.
Okay. So I want to see if there are thoughts or reactions to that while I also try to get back to where I was.
I know watching that video, I was just like, wow, that's so overwhelming. How does a person face that every single day and probably in multiple areas, not just getting ready. And I just felt so much for that kiddo and then getting to school and being told he's irresponsible. Right. So
Right. That's a great point, right? That is how he starts his day. That is the first thing in the morning. That's not to mention any stressful, anxiety-provoking thing that might happen during the day or just normal, right? Learning, going through the day. It's exhausting. That's like the third time I've watched it, and I have like a personal reaction. Like it makes me anxious to watch it. It's a lot. And it was created by a teenage boy for actually a class assignment for his psychology class. And he has OCD. And so he just wanted to like show what just a morning ritual, a day in his life looks like. And I'm wondering if there are some things that people noticed in his room or in his environment that kind of stood out that maybe are interesting or we should note. And it's okay if you didn't notice.
I really like the video. I think it's helping me understand like the complexities with how many different components that it affects of their daily life. And I noticed his bathroom, the items were like lined up, but his bedroom seemed like, other than the ficus with the eyeglass case, that it was sort of, I don't want to use the word normal, but like an average level of like not hyper like lined out like the bathroom was.
Exactly. That's exactly what I wanted someone to notice. So great point. Yeah, his room was not perfect. It was not symmetrical, tidy, right? Clean. It looked like a normal teenage boy's room, maybe a little cleaner than a normal teenage boy's room, but the stuff on the dresser wasn't in order, right? He kind of made his bed before he left, but even the bathroom, like, I don't know if people noticed, like the clock in the bathroom was like kind of gross around it. And these are some of the misconceptions, that if he's not perfectly tidy, if his room is messy, if there are things that are gross or unclean, he can't possibly have OCD. But it's, again, not rational. It can be that he needs one thing to be perfect and symmetrical and clean, and it doesn't apply to everything. He is still, an average teenage boy. He just also has OCD, which is not rational.
I have some comments in the chat as well, Dr. Vaughn.
Okay, great.
Ribbons on the door needed to align
Yes.
bathroom items. And then Dr. Swagger, the severe functional impairments and just getting through things and how much time it took were highlighted in that video.
Exactly. 100%.
I appreciated the internal battle that you saw the individual go through, because you have your side of yourself that's telling you like, oh my gosh, what are you doing? And then the other side is it's a fight, like an internal, logical and not rational.
Exactly. Yeah, I think he did a really good job of showing exactly like that ego dystonic quality that I was talking about, which is you can argue with yourself that you don't need it and it doesn't make sense and it's stupid and it's irrational, and still have the absolute urge and need to do it. Otherwise you will feel anxious. And so another misconception, right, is that like, oh, I just need it to like look pretty and then I can leave. And you don't hear or see that entire internal dialogue that's happening. And I wanted to say this early on and I forgot. It is normal to have intrusive thoughts. We all have intrusive thoughts. It is normal to have a couple of these things that we feel like we have to do until it's just right, but it doesn't look like and sound like this impairing disorder for everyone, right? And that it really is the difference. And I love that, Kelly, you pointed out the ribbons, because when I look at that, I'm in awe of how many ribbons there are, meaning this might be an overachiever. He has a lot of things going for him. This might go unrecognized because he's doing amazing in school. He never gets in trouble. No behavioral complaints, no problems with his grades. You're not seeing the functional impairment because it's so hidden, because it's so internal, right? I'm seeing a few more things. The internal conversation going on in the mind has to be exhausting. Absolutely. I had a patient have the compulsion to choke herself with her toothbrush every morning. She felt like if she didn't, her parents would die. Yeah. And I hear that a lot of the times, especially with kids and teens, it's, if I don't do this thing, someone else will get hurt or harm will come to my attachment figures, my family, or myself. Which of course, that internal dialogue might be going on like, that's stupid, but I have to do it. Right? Yeah. So as you might imagine, there's a lot of noise. There's a lot of activity going on there. So this is a picture of a SPECT scan of like kind of a normal typical brain, no diagnosis, versus one with OCD. And as you can kind of see in like the frontal region, there's so much anxiety, there's so much energy, there's a lot of brain flow, more activity than you would expect a normal person to go through. And that was just his morning, right? So if we think about how exhausted he might be by even midday, you know, it just makes you really feel for like OCD is a lot. And again, like the more we can understand, the better we can actually like ask the questions and get to recognize it, so that we're not missing it. Okay, so there are some kind of theories about what could be going on. Some newer-ish research kind of says that there is this feedback loop in terms of your frontal lobe, that area that we just saw with all that activity, the striatum and the thalamus. In typical individuals, the three parts would communicate. So the frontal lobe is, you know, really going to be the area where you make decisions, and it should alert you when there's like an error detection. You should have goal-directed behavior. It sends a signal to the striatum, which either passes the signal or acts like a brake and inhibits it if it's like, oh, you don't need that. And then next, the thalamus is supposed to control subconscious movements. And it receives a signal from the striatum, sends it back to the frontal loop. If the signal's too loud, it can really disrupt activity. And there's a theory that OCD might actually result in dysfunction in this loop, where there's supposed to be good communication. If there's something you don't need, right? Like you shouldn't have to go through and do it. And that's where we're seeing like that. Your thoughts and your behaviors are really not aligned here, as we saw in that video. So there is some misfiring happening and a ton of activity, but obviously like these brain areas are not communicating in the way that we see in a typically developing brain without OCD. Okay, so Elizabeth had asked a very important question, which is how common is this? You see it in about 1 in 40 adults, 1 in 200 children to teens. So this is about overall like 1 to 2% of the population in terms of adults with OCD. Women have a slightly higher rate of having it than men. However, in children, you're more likely to see it in boys because there's a typically earlier onset in males than in females. But you can see it in childhood and adolescence. I have worked with 10-year-old boys, and I've also worked with 18-year-old boys with OCD. And I've worked with 13-year-old girls and also 19-year-old girls with OCD. But the average age of onset is about 19 and a half. Although I would say about a quarter would see emergence by about 14 years. Like middle to late adulthood, you really don't see onset there. So like onset after your 30s is unusually rare. And on the other side, about a quarter of males have onset before age 10. So I know that makes it seem a little bit unclear, but what you're really seeing is earlier in boys, a little later in girls, but childhood and adolescence absolutely can be affected by OCD. If you do have the onset earlier, then you're less likely to kind of see remission without treatment. So earlier onset usually does lead to more complicated obsessions that have been reinforced by compulsions, more complex rituals, especially without treatment. Those things can get really reinforced, and then that becomes even harder to treat. So earlier onset and gradual onset really leads to a less likely to see remission into adulthood, especially without treatment. In terms of causes, like most of our psychiatric disorders, we can't give a definitive cause, but we know that all genetic, psychological, and environmental factors contribute. And there is relatively high heritability rate here, between 35 to 50% is what the most recent stat I saw. And And like in my own experience, I see it run in families. So if your mom or dad had OCD, you are at a significantly greater risk to have OCD yourself. There are also a ton of comorbidities, especially anxiety disorders. So the vast majority of those with OCD don't only have OCD, they also have other anxiety. And that makes sense. Can you imagine that boy that we just saw going through that morning ritual, maybe not also having GAD? It's possible. I think we'd rather just, you know, drive the OCD treatment. But he might also have GAD, social anxiety, specific phobia, separation anxiety, especially if the fear is like something bad might happen to someone I love. Yeah, it's pretty likely that you'll see it. ADHD can also be comorbid. Depressive disorders, about 41% also have major depressive disorder, which you can imagine that, you know, this could make you feel pretty bad. Could be pretty isolating. About 30% of individuals also have tic disorders. That's also more common in children. And then 39% of adults also have comorbid substance use disorder. I'm gonna go a little faster for the sake of time. So usually SSRIs are the go-to psychiatric treatment. So usually what I've seen is sertraline or fluoxetine being prescribed. But then for treatment on the psychological side, CBT is the gold standard, and specifically exposure and response prevention. ERP is a type of intervention. It's a form of CBT that's specifically catered to that OCD cycle. So what is ERP? It's a evidence-based intervention aiming to break that cycle that we saw, where you are gradually facing situations that provoke your obsessions, but then in order to break that cycle that reinforces your leading to a compulsion to break the anxiety, you actually block ability to do the ritual, block compulsive behavior. So the overall goal is not to get rid of the obsessions. It's to help the patient tolerate that discomfort and anxiety that's brought about by the obsession while they just don't do or don't engage in their ritual. So really bringing control to the individual to really believe like OCD does not have the power that they do. So similar to like anxiety treatment in general, there's always that exposure component, but this added component of really blocking the behaviors that have been learned, the compulsive behaviors. So kind of what this looks like is over time, you have anxiety on the y-axis. It goes up, you do the ritual to get rid of your anxiety, immediate relief. But then the anxiety comes back, you do the ritual, immediate relief. But then this just keeps the cycle going. Whereas with, you know, all exposure graphs that you'll see, on the y-axis, you have anxiety. Your anxiety peaks, it feels really bad and it feels bad for longer because we're not doing the ritual. But you have to write it out so that you learn that that bad thing didn't really happen, that OCD is lying to you. It's not going to feel better immediately. You have to keep exposing yourself and keep exposing yourself. And you really have to ride out that anxiety for a long time, but then you'll see that the intensity of the anxiety decreases over time. This is another graph kind of showing the same thing. Once you get rid of that ritualized behavior, the anxiety habituates, and that is the goal. So a meta-analysis on 20 RCTs found large effects for CBT efficacy and moderate effects for SSRI efficacy. And the greatest effects were associated with those who have actually co-occurring anxiety disorders. They were more likely to see a great effect in treatment. More therapeutic contact, as you might imagine. This takes intensive treatment. You can't just sporadically show up for therapy. You have to really consistently show and do the homework. And then low treatment attrition. So there are high dropouts rate for ERP because it's really distressing and it's really hard and challenging. But for those folks that can stick with it and then have a support team that keeps them coming, keeps them supported as they're doing ERP, they are most likely to be successful. This meta showed that about 68% of patients who completed CBT showed improvement in symptoms, and 57% were actually in remission after treatment. So the kind of takeaway is ERP alone or ERP and an SSRI are way better than just medication alone. So whenever possible, we really want that learning to happen. So if we take all of this together, this is what the CBT model looks like. You have, and I'm just going to use the example of contamination because it's one of the most common that we see. You have a contamination thought, it leads to anxiety. And then that fear learning happens where you have the thoughts in relation to a stimuli, let's say bathroom door handle. Oh my goodness, I don't want to touch it. You get anxiety. And so over time, because you've learned that fear, it actually generalizes to other stimuli related to the bathroom door handle. So if the bathroom door handle is contaminated, maybe my work door handle is also contaminated, and then it becomes the car door and then the home door. If we keep engaging in that OCD cycle, it's only going to make that fear generalize to more and more contexts and more stimuli. So as you can see, that ritual comes in where once I have the obsession, that contamination thought comes in, I have anxiety, I'm faced with the stimuli, greater anxiety, I engage in the ritualized behavior. Oh, I feel better because I'm no longer having that obsession. And then now my behavior has been reinforced and I'm going to probably keep engaging in that ritual because I felt better. And in ERP, they're still going to have to face that stimuli, but you're going to break the cycle by not allowing them to engage in the ritualized behavior. So instead of doing the compulsion, and first you would kind of walk the patient through this literally with you in session, go to the bathroom, make them touch it, write it out with them. And of course, you know, on the side, you're doing all sorts of relaxation to, you know, make sure that they're learning other things they can tell themselves or do on the side, but you're preventing them from carrying out the ritual. And eventually, because you'll remember that graph, you have to do it over and over and over. Eventually, the goal is to learn extinction so that you feel better without engaging in the ritual. Okay. Any questions?
While you think of some, I just want to say thank you so much, Dr. Khan. That was excellent presentation and you did perfect on time. And while you do questions at the end, I am going to launch our monthly at the end poll if you guys want to stick around for that. But thank you so much. Dr. Swagger said, does anybody have any questions or comments or examples? Thank you, Kelly.
Incredible presentation. Thank you so much. It was so, you presented in such a way that it was so very understandable. So I appreciate that. I'm just wondering, in working with kiddos, right, young kids, and where you see some of this, but you may also be teasing out for kind of that autistic piece, because, you know, some research shows like 17% of folks, kiddos diagnosed with autism could have a co-occurrence with OCD. So how do you, in your practice, kind of tease that out to know which one you're really looking at?
Yeah, great point. They can definitely co-occur. I would really, in my own practice, I would give an assessment. So I didn't include it in this presentation, but for children's, I would give the CY box. And it is an incredibly comprehensive assessment tool that has every sort of obsession and every sort of contamination listed on it. And so if I'm kind of trying to get organized, I always just go to what already exists in the evidence, and it is to assess. And so I would assess so that I get a more thorough understanding of what's all going on, because without asking, I can't assume that I know, since some of it can be so internal. Yeah. But if anyone wants, I have, and I think some of these are on the drive, but I have the CY box for children, the Y box for adults. Those are really the go-to gold standard measurements, and they're quite comprehensive. They take some time, but there's also self-reports that you can just give patients, especially adult patients, that they can just complete on their own.
Thank
I
you.
would just add, that's a great question. I would just add to that too. You know, to have the diagnosis of OCD, you don't have to have both. You can have just compulsions. I would say in the type that's related more to autism, although this is not entirely true, there tends to be, I think, higher prevalence of the compulsive behaviors, and often it's not attached to the anxiety obsession piece and some of the straightforward autism. Again, you can certainly have both, but I think teasing out the compulsive nature of the behavior, and often there's also some difference in distress, and I don't know if Dr. Khan would add to this as well. Oftentimes the compulsion, the purpose of the compulsion is often actually very self-soothing and relaxing to a lot of kids with autism, while it's much more distressing as a rule in OCD in terms of that ego dystonic, syntonic kind of behavior. I mean, that's not completely 100%, but that can kind of really help, I think, tease out the purpose of a behavior in particular between those two. But it can be really hard, especially in young kids that can't communicate their internal world, and often I've seen people misdiagnosed either which direction because the child's not been able to really verbalize it, and you just have to do a lot of pattern mapping to try to sort of understand those antecedents. But it is tough.
Absolutely. Great question. I'm going to go ahead and launch a poll, but please feel free to continue discussing if you have time.